Hi there, folks. Quick announcement. If anyone is here earning their LGBT health certificate, this is a session that counts towards that health certificate series. I have clipboards both with me right here. If you want to just raise your hand, I'll make sure to get you signed in. Or afterwards, you can also sign in at the little table out front. So just be sure to sign in if you're getting credit for the LGBT health certificate session. Raise your hand if you need this.
Excuse me, for the students that are in the N374 class, which is the Research for Evidence-Based Practice, there are actually 2 sign-in sheets passed around, and it says N374. So you need to sign one of them. I'm going to start another one on this side of the room, so please make sure you sign in before you leave today. Thanks. And then we'll come around and pick it up. Thanks.
If you have a seat that is vacant beside you, would you mind raising your hand so that we can get everyone a seat? Anybody have a vacant seat beside them? No? Okay, there's 2 over on this side. Would you raise your hands again? Okay, over this way. And we have seats on the front.
Ray, how are you?
Thank you, Vicki. Can you believe it? It's wonderful. Oh, you brought the camera. right here. You want to go ahead and give her, she's got her microphone. All right, I think we just about have most folks seated. I see a couple of empty seats up here. There are a couple of seats up here. Those of you who don't have a seat, if you would like to come up. No takers? My name is Lynn Hall. I'm the Associate Dean for Research in the School of Nursing. And I have to say, I am completely overwhelmed at this wonderful crowd we have here today for Dr. Hughes's presentation. I want to thank each and every one of you for coming to hear this internationally renowned speaker that we had the good fortune to have today as our Research Louisville presenter. I want to begin and thank Stacy Steinbach. Stacy is the director of the LGBT satellite office here in the Health Sciences Center. Stacy partnered with us, and those of you who are enrolled in the certificate program, we're very happy to have you here with us today. I'd like to begin and tell you a little bit about Dr. Tonda Hughes. She is a native Kentuckian. She grew up in eastern Kentucky. She received both her associate degree and her bachelor's degree from Eastern Kentucky University. She went on to obtain a master's in psychiatric community mental health nursing at the University of Kentucky. And then from there, pursued her PhD degree in nursing science with an emphasis or concentration in women's health at the University of Illinois at Chicago. In addition, she did a 2-year postdoctoral fellowship in gender differences in substance use and abuse with the UIC Prevention Research Center, which was housed in the School of Public Health. Dr. Hughes currently is professor and associate dean for global health in the College of Nursing at UIC and an adjunct professor in the School of Public Health. She is co-director of the university's Building Research Careers in Women's Health program. She holds many honorary professorships. She particularly loves her attachments to universities in Australia and New Zealand. She is highly sought out as a consultant and distinguished speaker. And she also holds an honorary appointment at the University of Pennsylvania. She's had a very distinguished career in substance abuse research, focusing on women. Over her career, she's had more than $20 million in funding, which is absolutely amazing. Her pioneering studies on the predictors and consequences of alcohol use among sexual minority women have been funded by the National Institutes of Health since 1999. So she has a tremendous track record. And that's something that is difficult for a researcher in any discipline to maintain funding for that long a period of time from the NIH. She also has grown her program of research into the world's largest running longitudinal study of alcohol use and health among sexual minority women. She leads or co-leads as another part of her role as Associate Dean for Global Health, several international capacity building projects, building partnerships for innovative nursing education and research to advance public health in India, which is a funded project. She also is doing work in Rwanda to improve human resources for health there. And she's also working in other countries related to global health and health problems, specifically related to communicable diseases. And in these projects, she takes students and faculty all over the world to work with educating nurses and caring for people in other countries. Dr. Hughes has more than 150 peer-reviewed journal publications, book chapters, and other scholarly works. She is a consultant to many countries, and she has achieved significant honors, many at the national as well as the international level. Those of you who know what Sigma Theta Tau International is, she is one of 100 nurses that has been inducted into the Sigma Theta Tau International Hall of Fame. She's also a member of the American Academy of Nursing and has received the Betty Ford Award from the Association of Medical Education and Research in Substance Abuse. Those are just but a few of the many accomplishments of Dr. Hughes. And Tonda, we are so delighted to have you here with us today. Thank you for coming back to Kentucky.
Thank you, Lynn and Stacy, for inviting me. I love coming back to Kentucky. Even though I've been in Chicago for 30 years, Kentucky is clearly my home. It's in my heart. So thank you for allowing me to be here and share my research with you. I was thinking when Lynn was talking, my dad would be so proud to hear all that stuff. I've had a great career, and I got my great start here in Kentucky. So I'm going to talk today about the development of not just my research trajectory, my program of research, but sort of how I got from being a little snotty-nosed kid in eastern Kentucky to where I am today. And I will be talking about my research, and I was wondering how many of you plan to have a research career or plan to do research. Can you just show me your hands? Okay, not as many as I would like to see, but there's a good number of you, and I hope that you'll change your mind as you go through your program. And I also hope that what I have to say may help inspire you to take a few risks when you're doing your research, and to really dream big, and to not let anything stop you from what you want to do. So let's get started. I'd like to just begin with a quote from Hillary Clinton's address when she was Secretary of State. This was an address to the United Nations in 2011. She said, "I want to talk about the work we have left to do to protect one group of people whose human rights are still denied in too many parts of the world today. In many ways, they are an invisible minority. They are arrested, beaten, terrorized, and even executed. Many are treated with contempt and violence by their fellow citizens, while authorities empowered to protect them look the other way or too often even join in the abuse. They are denied opportunities to work and learn, driven from their homes and countries, and forced to suppress or deny who they are to protect themselves from harm. I'm talking about gay, lesbian, bisexual, and transgender people. Human beings born free and given bestowed equality and dignity, who have the right to claim that which is now one of the remaining human rights challenges of our time." So, to me, that sort of emphasizes why I have done the work I've done. There's been some really good times and some not so easy times, but it's all been very rewarding. So let me tell you now just a little bit about why I focused in this area. Since my PhD, I have been focusing, as Lynn said, on women's health. And I learned early on during that period that most of the research, most of what we know about health most of the research has been conducted by male researchers and has focused on men, so that even really serious life-threatening conditions, we know how to treat those, but we know how to treat those much better in men. And what I'm going to do is to tell you first my objectives, which I should have done before I started on that little tirade, but let me back up and tell you now what my objectives are for the presentation, and then I'll pick back up on the sort of disproportionate focus on men in research. So I'd like to provide an overview of my research development, including why I chose to focus on sexual minority women's health, and then highlight some of the most interesting findings. I won't talk a lot about statistics, so don't worry too much about that. I'll describe some of the barriers that I encountered, and I'll describe future directions for research related to sexual minority women's drinking and health. So back to the focus of men. So you all heard about the issue that we learned that aspirin was effective for heart disease in men, for helping prevent a heart attack. All that research was done on men in the beginning, and we had no idea of how it would affect women. We're learning more, but still there's a big gap in research on women. So even most of the research has been done with men, and even animal research has been done with male rodents and other animals. And as this book indicates, most of those rats were white as well. So in 1990, the Government Accounting Office, which is the overseer of the National Institutes of Health, they criticized NIH for excluding women from most studies that involved diseases, treatments, and drug effects, and for devoting only 13% of its research funds to women. Now, that should make some of you in the room, especially women, pretty mad. And things have improved, but there was just something that came out this week that even though women are being included in equal proportions in clinical trials, researchers aren't reporting the data in ways that help us understand better the differences between men and women. And it was not until 1993 that the NIH was required to include women in clinical trials, unless they had some compelling reason not to do that. So that research really set the stage. That was a discovery that I made, and that discovery really changed the direction of my work. And what I learned during my PhD program was that just as women had been excluded from research in general, sexual minority women were being excluded from research on women. One article that really points this out in very clear terms is a paper from the American Journal of Public Health. In this paper, Uli Boehmer from Boston University reviewed literature in Medline, all of the literature indexed by Medline, so millions of articles. And between 1980 and 2000, what she found was that only 0.1% of all articles focused on sexual minorities. So tiny little bit. Of those, the majority focused on gay and bisexual men. And of those papers, of those articles, almost all of them focused on sexually transmitted infections, especially HIV and AIDS. Just over a third of that 0.1% of articles focused on lesbian or bisexual women. So very, very little research had been done until the year 2000. Now, similarly, a little bit later, another American Journal of Public Health paper came out that did a similar kind of review of grants that were funded by the National Institutes of Health. How many of you know what the National Institutes of Health are? Major funder of research in the United States, billion-dollar budget, much more than that. So in 22 years, between 1989 and 2011, sounds pretty good, 628 studies related to LGBT health, but again, only 0.1% of those focused on any aspect of LGBT health other than HIV or AIDS. And of those, of that 1%, only 13.5% focused on lesbian or bisexual women. Now, if any of you have questions or don't understand or would like me to define something, please don't hesitate to ask, to raise your hand, and I'll clarify whatever question you have. Before 1980, there were very few studies of lesbian health, handful really, and most of those studies focused on lesbians drinking. And that may seem a little odd, but interestingly, one of the only places that you could find sexual minority women, lesbian or bisexual women, was in gay bars. So researchers decided they would go to gay bars and recruit their samples there. And hey, since they were pretty sure everybody was drinking, why not do studies on alcohol consumption? And can you tell me what these researchers found? Can you guess? A lot of drinkers, like probably most all of the people they studied. And they also found heavy drinkers because, of course, if you go to a bar and you recruit a sample, you're going to get a disproportionately high number of heavy drinkers. So based on these studies, there were estimates in the literature that at least a third of all lesbians had alcohol problems or were alcoholic. So my work over the past 20 years or so has been about trying to provide a more scientifically grounded and realistic appraisal of what's really going on with these people. So that's how I got started. But I wouldn't be here today if it weren't for a whole lot of people, including some of my academic advisors from the University of Kentucky and many others along the way. I definitely can't take credit for my success by myself, that's for sure. But in addition to my academic mentors, I also owe a great deal to my parents. I'm the daughter of a coal mining father and a Jill of all trades mother. I grew up in rural southeastern Kentucky on the Virginia-West Virginia border. And even though neither of my parents had a college education, they were the biggest proponents of education of anybody that I knew then and really still know today. So that's me on the far right in the coal miner's outfit there when I was considerably younger and teaching at the University of Kentucky. Like most people from Eastern Kentucky, I got married when I was pretty young. I was 20 years old. But I wasn't nearly as young as my third cousin, Lord Lynn, who got married when she was, people used to say 13. I think it's been revised now to 14 or 15, but pretty young still. And this is my only claim to fame. I can't sing, so please don't ask, but I do like to drag this out at parties and, tell people about this one aspect of my life. As Lynn mentioned, I got my associate degree at Eastern Kentucky University just before I got married, and I got my bachelor's degree there just after I got divorced. So Eastern was a good place for me in lots of ways. I went to the University of Kentucky because they had traineeships then in psych mental health, in community mental health, and it was actually a world view changing experience. I had wonderful mentors there. I don't know if any of you would know Melba Jo Hendricks and Gretchen Lagadna. They were our primary mentors, and you may see Ruth Staten, for those of you who know her. She's over in the corner of that group at the bottom. Topsy and I were classmates and good friends and have continued to be since then. This program was influential in many ways. One of the ways it was influential is that it actually launched my career in the direction of substance use among women. When we were students, our advisors were approached by the Kentucky Board of Nursing to help develop a program that would serve as a support to nurses who were having problems with alcohol and other drugs. So we helped Joe and Gretchen develop a program called Nurses Assisting Nurses. And in this program, we, as psych mental health people, we provided counseling, and we also collected data so that we could better understand what the risk factors were for nurses in terms of alcohol and drug use. And this was really quite remarkable at the time, because even though programs had been around for physicians for a number of years, there was really very few programs like this for nurses. Nurses were typically left to their own devices. They usually were fired from their job and then left without resources to seek treatment. So it was a really good program. I then went to the University of Illinois at Chicago primarily because of its very strong women's health program. This was in the early to mid 1980s, when the women's health movement had just begun. Nursing academic faculty at that time were there were leaders in the field of helping to lead that movement, and they, and particularly these three mentors, helped to change the focus of women's health from reproduction to the idea or the perspective of women as experts in their own health. So it was really an exciting time to be there. I finished my dissertation in 1989. I did a dissertation on chief nurse executives' responses to chemically dependent nurses. And it took me 5 years to get my PhD, and part of that was because I had a mentor who believed that I needed to do a lot of things to be socialized as a professional and an academic and a researcher. So I co-edited the first book on addiction in the nursing profession. I was associate editor for a local university publication called Nursing Scan in Women's Health, and I co-edited a special issue on nursing clinics of North America that focused on women's health. So these things, like I said, undoubtedly delayed my completion of my dissertation, but they were really instrumental in my career because, for one thing, I was invited to join the faculty on the tenure track at the University of Illinois. So I was launched early out of my PhD. Shortly after I started as a faculty member at UIC, I applied for and was awarded a postdoctoral fellowship. As Lynn said, it focused on gender differences and patterns of alcohol and other drug use. And that was a wonderful program because certainly I gained expertise in the substantive area of substance use among women, alcohol use in particular, and research and statistics. But what was really important, what were the networking opportunities that provided? I went to a lot of national conferences and met a lot of leaders in the field. And it was really one of those conferences where I met my current and long-term mentor, Sharon Wilsnack. She was at the time at the university, she is still at the University of North Dakota. She's the leading researcher in women's use of alcohol, and probably not just in the United States, but in the world. And I heard Sharon say, this was, again, in the early 90s, and at that time, we still didn't know very much about women in terms of their drinking, just like we didn't know much about them in terms of their health. So she would say things like, we know this much about women's drinking in general. We know this much about African American women's drinking, this much about Hispanic women's, and nearly nothing about lesbian and other sexual minority women. So after hearing that, I approached her and asked if she would be willing to co-author a paper, a review paper, because I wanted to show how those early studies that indicated that a third of lesbians were alcoholic, I wanted to show that those that couldn't be the case, really, and that the research was flawed and we needed a lot more better research to understand the issue. So that started a very long collaboration, and for any of you who are thinking of, who are just launching or are in the early stages of your career, if you can find that one mentor, especially who's credible, this is important, I think, for everyone. But if you're working with a vulnerable population, it's even more important to do that, or with a stigmatized population. When I started the work, sexual minorities were very stigmatized. They still are very stigmatized, but even more so at the time. So when I began this work, even though I didn't realize it, my work then and now has always been based on health equity and social justice perspectives. These perspectives are critical when you're working with vulnerable and marginalized populations. And even though we have made a good deal of progress in many parts of the world, there's still a great deal of work to do, as was indicated in the speech to the United Nations. For example, there are 75 countries in the world where it's illegal to be gay, to be lesbian, bisexual, gay, or transgender. And in at least 10 of those countries, LGBT people can be put to death. And even though things have changed a lot in lots of parts of the world, in the United States, we still have a ways to go. In 29 states in the U.S., it's legal to fire someone for being out as gay, lesbian, or bisexual in the workplace. We have gay marriage, but it's still employers can still fire LGBT people in the workplace. And in fact, it's worse for trans people. In 34 states, employers have the legal right to fire people who are transgender. So LGBT people make up about 4% of the U.S. population by all our best estimates. That's, hard to estimate because a lot of people don't feel comfortable being open. But say we have 4% of the population, 19% of all hate crimes in the U.S. target sexual minorities. And the hate crimes that target them are much more violent and vicious than our hate crimes that target other minority groups, such as those based on race and religion. Now, among the most egregious forms of hate crimes perpetrated against sexual minority women is a form of homophobic rape called corrective rape. It's called that because the perpetrators often give that as a reason. They say they want to correct a woman's lesbianism, or they want to show her what it's like to experience a real man, or things like that. And many of these reports come from South Africa. In fact, the woman, the soccer player, I think you're right, she was a very famous soccer star in South Africa, and she was brutally raped and murdered a few years ago. And even though we know most about corrective rape from South Africa, it happens in many, many other countries. It's been documented in many countries. It probably happens in most countries, and including the U.S. and Canada. So South Africa, just in case you're tempted to conflate it with Uganda and Nigeria and some of the places where there's really pretty repressive policies against LGBT people, South Africa is one of the most progressive countries regarding sexual minorities in the world. In fact, they were the first country in the world to include protection for sexual minorities in their constitution, and they were the 5th country in the world to legalize same-sex marriage. So this goes to show you, even when you have protective and supportive and progressive policies, those don't always translate into everyday behavior and actions. So it's really important that we continue to work toward equality and health equality and equal rights for all our citizens in the United States and elsewhere. So I first began my career, my research career that focused on sexual minority women with a health needs assessment in Chicago. This was done in collaboration with our Chicago Department of Public Health. And one of the most surprising findings at that time, not surprising at all to me now, was that twice as many of the lesbians as the matched heterosexual controls reported childhood abuse. We then replicated the study in New York City, St. Paul, Minneapolis, and Columbus, and we found 2 to 3 times as the rates of childhood and adult victimization among sexual minorities as among heterosexual women. So, given these high rates of victimization, you have to wonder what is the impact on this population. So, in conjunction with these studies, I started to develop my own research project, which we called the Chicago Health and Life Experiences of Women Study, long name. We call it CHALU for short. And we called it that because it was designed to replicate Sharon Wilsnack's National Study of Health and Life Experiences of Women, which was a 20-year longitudinal study of women in the general population. We did some pilot work with Campus Research Board funding to test the questionnaire, and then we applied for, and I was awarded a Research Career Development Award, in which we recruited our baseline sample for the Chicago Health and Life Experiences of Women study. We're fortunate that that study was designed to address many of the methodological limitations that were identified in a landmark report by the Institute of Medicine that came out the same year that the grant was funded. This report was on lesbian health. At the time, there was so little known about bisexual women, they couldn't even be included. But our study addressed the major methodological issues that were identified, including the lack of appropriate heterosexual comparison groups, the over-reliance on small and homogeneous samples. Most of the studies until then were based on where the samples were white, well-educated, and relatively young women, and there were absolutely no longitudinal studies at the time. So here's what my baseline sample looked like. And remember, we did this on a training grant award, so it took us 18 months to recruit the sample, but we wanted to get a more diverse sample, and we did. Of the 450 women, the age range was from 18 to 83. A lot of the women were in the lower income bracket. Fewer than half of them were white. They did have a higher level of education, but this has been shown over and over, even in probability studies, to be the case. Sexual minority women and men tend to be smart and get a lot of education. And about 2/3 of them were in committed relationships, and about 1/3 had at least one child. So we replicated the same instrument as in the national study and used the same methods so that we would have a comparison group. We collected data in face-to-face interviews, and we found some really interesting things even in this early study that was pretty much descriptive. First of all, for those of you who know the literature, white women in our population, in the American population, are much more likely than black women to drink, and to drink heavily. But in our study, we found that African American lesbian women were about 3 or more times as likely as white women to report heavy drinking. We defined that as 2 or more drinks per day on average. Similarly, unlike women in the general population who tend to decline or reduce their drinking with age, especially at around age 40 or 50, we found that sexual minority women tended to continue to drink at about the same levels, the same rates of drinkers over time. And this is important because prolonged, and especially prolonged heavy drinking, can have serious cardiovascular effects and is related to some forms of cancer. So we've been fortunate enough, the CHLU study is now in its 15th year. We got 2 more large grants from the National Institutes of Health. The first one, we just wanted to follow them up to see how things might change over time. And in the second one, we were very interested in the accumulation of stressors over a woman's lifetime. So if you think about these women who had higher rates of childhood abuse, then this gets entangled with their sexual identity development. People who've been abused are more likely to be re-victimized. Then you overlay all that with minority stress, discrimination, harassment, fear of coming out, internalized stigma, and that sort of thing. And so to me, there's a trajectory of risk that develops that we need to figure out how to intervene with. So that's what the last study was about. And we also, in that we collected data in 2010 and 11 and into 2012. And we also added a new sample of bisexual women, more women of color, and also women who were 18 to 25. So now we have 727 women that we're following. And I'm very excited to report, and I don't know how much you all will get this, but I just got a score from the NIH last week that put me in the top 5% of scores. So we will very likely be funded to carry this study into 20 years and beyond. And because of the new marriage laws, we're going to be able to evaluate the effects of this supportive legislation on these women. I believe it's going to show a tremendous effect and that we're going to see a decrease in health disparities. So I'm very excited about that. Now, in addition to my own work, I've also been involved with a number of other large studies, some using probability samples, including a study in Australia and a couple in the United States using national data sets. And I've also been involved in some large non-probability samples that are also collecting large amounts of data and are helping us understand what's going on to create these health disparities. Now, rather than bore you with findings from all of those studies, what I'm going to do is just give you a few highlights of what I think are the most interesting and important findings. So I've alluded to this already, but if you look at, these are 3 studies that I was involved in. The CHLU, so my study, the NESARC study, the National Probability Study in the U.S., and the Australia Longitudinal Survey of Women's Health in Australia. Very different samples, very different methods, different designs, and you still see this pattern where lesbian and bisexual women, the yellow and the red bars, are much more likely to report hazardous drinking, and that's based on 5 different criteria: heavy episodic drinking, drinking-related consequences, alcohol-dependent symptoms, and intoxication, 2 more times intoxicated in the last year. I'm talking to college students. I realize that probably doesn't seem too hazardous, but in our study it is. Anyway, so you see this discrepancy. And then when you look at depression, the pattern, even though the values are different, the patterns are very much the same, but with even more dramatic, with bisexual women showing an extremely high risk of past year depression. So again, you have to wonder, what's causing this, and it brings me back to victimization. Every study that we've done, we have found that sexual minority women's rates of lifetime victimization are 2 to 3 times that of heterosexual women. In addition, childhood sexual abuse and childhood physical abuse appear to be more severe among sexual minority women than among heterosexual women. We've also found that risk behaviors and negative health outcomes vary substantially within the sexual minority women population, and that bisexual women tend to show the highest risk and the poorest outcomes. And this is an important point because we tend to look at a population group and sort of treat them or think of them all as the same. And we found that women who identify as lesbian and report that they've only ever had female partners, they look really similar to heterosexual women in terms of their risk and outcomes. So really important finding, in my opinion, and it's telling us, giving us some important information. Our study is still one of the few that doesn't just ask, do you identify as gay or straight or bisexual? We actually ask these intermediate categories. We allow women to say that they're not really exclusively heterosexual. They are mostly heterosexual. They're not really exclusively lesbian or bisexual. They feel like they're mostly lesbian or gay. And by doing that, we've found some interesting things. And we found that women who identify as mostly heterosexual differ in interesting and distinct ways from women who are exclusively heterosexual. And these are data from Sharon Wilsnack's national study. To summarize this chart, I would say that for every substance use outcome that we looked at, mostly heterosexual women were 2 to 4 times as likely to report these outcomes as were exclusively heterosexual women. Now think about this. I don't know, when you go to your general practitioner, if they ask you about sexual orientation, they may ask, are you gay or straight? If they're really enlightened, they'll ask you if you're bisexual, gay or straight. But not many, and we can understand why, are going to delve into this enough to understand who these mostly heterosexual women are. And they're very large numbers of them. They're much bigger than lesbian and bisexual women combined. So in national studies that ask this question this way, probably 10 to 20 times as many women will identify as mostly heterosexual as will identify as bisexual or lesbian. So we're missing this big group. We're missing opportunities to provide counseling and education. So something to think about. We've also we ask a lot of questions in this study, and we found that women who score higher on femininity, they have some protective things and some not so much. So women who are higher on femininity report lower levels of discrimination. They look just like everybody else, but higher levels of internalized stigma and depression. As, on the other hand, women who rate themselves as more masculine, they report lower levels of internalized stigma, lower levels of depression, but higher levels of discrimination, victimization, and hazardous drinking. So, again, there's a lot of nuances here. How many of you, I was talking with Stacy earlier, or somebody about pregnancy. It wasn't Stacy, it was somebody else. How many of you know that young sexual minority women are more likely to get pregnant than are young heterosexual women? Pretty shocking, huh? So we were wondering about this, and we thought that maybe a fair amount of that was because of unintended pregnancy. And so we looked at that in our study, and we found that 20% of the sample reported at least, and all of these are sexual minority women, they reported at least one unintended pregnancy. The women who were most at risk for unintended pregnancy were bisexual women, probably not surprising, African American women, and women with a high school education or less. However, of those who reported unintended pregnancy, 50% of them said they were exclusively or mostly lesbian. So there's clearly some things going on here. We think it could be partly, conflict around identity, trying to prove to oneself that you're straight. It could be coerced sex. It could be rape. There could be a lot of things going on, but it's really important, I think, and has been overlooked in the past. We also found that unintended pregnancy was positively associated with depression and hazardous drinking later in life. And not surprisingly, we found that a large proportion of the women who reported unintended pregnancy also reported childhood sexual abuse or childhood physical abuse. And we found that these two life experiences mediated the relationship between unintended pregnancy and depression, but not between unintended pregnancy and hazardous drinking. So there's something more complicated going on with drinking. We were also one of the few, are still, but we're definitely one of the earliest research teams that looked at all three dimensions of major dimensions of sexual orientation. So there are three. There's the cognitive aspect or identity, how a person sees themselves, identifies themselves. There's the romantic or sexual attraction part, and then there's the actual behavior. This is the gender-bred man, I think it's called. I got this on the internet. I thought it was pretty cute. But so now if you look at the combinations of these dimensions, you find some really interesting things. For example, we found that women whose sexual identity matches their sexual behavior and their sexual attraction, those women are at lower risk than those whose identity doesn't match their attraction or behavior. And this extends to not just alcohol and depression, but lots of other health outcomes. We also found that women whose sexual identity remains stable over time have lower risk than those whose identity changes. And this is true regardless of whether they go toward being less same-sex attracted or identified or more same-sex attracted. So it's a change in a person's identity that's having the impact. And just so in case you're wondering, about 10% of our sample changes their identity between waves. This is a real interesting thing. This is true for women, much less true for men. Gay men and bisexual men don't change their identities as much. We think it's because women have more freedom, to express their sexuality than men do, perhaps. But anyway, it's a very interesting thing and an important thing that we have found. So we've come a long way since when most of what we knew about sexual minority women was based on information collected from people recruited in gay bars. But there still is much more to learn about the underlying causes of sexual orientation-related health disparities. We are moving in that direction. We were fortunate in the last data collection wave, I told you it was between 2010 and 2012, that in 2011, Illinois passed a civil union bill. Now, this is way before marriage, or not way before, but somewhat before. And we found that women, we'd interviewed about half when this bill passed, and about half after. And we found that those interviewed after the bill was enacted showed better health outcomes, including lower levels of perceived stigma and discrimination, lower levels of depressive symptoms, and lower levels of hazardous drinking. So these supportive policies appear to be having a beneficial effect. Interestingly, these benefits were most apparent for Black and Latino women and women without college-level educations, suggesting that the most vulnerable groups may benefit the most from policies like this. So, as you all know, now same-sex marriage is legal throughout the country, but it was legal about a year earlier in Illinois, so we were really excited when we started to initiate this grant proposal, which went in before marriage was legal in the full United States. And we're excited because, you know, we have this aging sample, and we're going to be able to tell stories like this about these two women in Iowa who were in their 90s, who were, after 72 years of being together, were able to get married. Isn't that incredible? So it's one of the best things about my job is being able to give voice to groups that are often invisible. And we hear a lot of positive things from the people who participate in our study. And I'll just read you a quote from one. It sort of exemplifies what women tell us. This participant said, "Thank you for doing this study. I didn't know that anyone cared about lesbians' lives or their experiences. Spending time with the Chalou interviewer and reflecting on my life helped me realize that I'm doing pretty well and that I've accomplished a lot. Just because I'm not heterosexual doesn't mean that I'm less than anyone else or that I deserve less than anyone else." And every year we get a card in the mail from a couple who've been part of the study since the beginning. They send us a check in the amount that represents the number of years that they've been together, and they thank us for what we're doing to support sexual minority women's health and their lives. And it's things like this that help me know that I'm making a difference. And if you can do research or do care that helps you know that you make a difference, then it makes it all really worthwhile. And it's actually gotten me through some rough times. When I first started this work, there were several senior faculty who I respected a great deal who encouraged me strongly not to study lesbian health, at least not until I had tenure. But luckily I didn't take that advice, and it has never, I've never regretted not taking that advice. It also, here's one more example of a sort of a big bump in the road. You're all too young to remember this, but in 2003, the NIH, a right-wing religious group, put together a list of NIH-funded grants, which they called indecent, a lot other sort of bad words, and wanted NIH to prove that there was some benefit to these studies. Now, my study has almost nothing to do with sex. We do ask whether women have had sex with men, women, or both, but relatively little about sex. I think my study was on the list because it had lesbian in the title. And even though I was in good company with researchers from Harvard and Johns Hopkins, this was chilling because NIH was calling researchers, and there was some idea. There was at least one study that almost got their funding rescinded. So it's that kind of thing that, you know, is a little scary when you're out there in an area that's not, how shall we say, not highly respected, that everybody doesn't agree with. But it's been worth it to me because the benefits have far outweighed the negatives. I've gotten lots of good press from some local newspapers and some national newspapers. But every time I get a grant funded, the internet is full. I mean, hundreds of these kinds of blogs come out about government spends nearly $2.7 million to study booze-loving lesbians, and Obama spends nearly $3 million to study why lesbians are drunks. Totally taken out of context. And what this says to me is people who write these don't believe that lesbians are worth taxpayers' money, that their health is not worth us spending our taxpayer money on. So I'm gearing up. I'm going to put on my slick suit or whatever so it can roll off for when my next study is funded, because I figure it's not going to be any prettier. But anyway, I feel very fortunate to be living in these historic times when the work that I'm doing, I believe, is making a difference. And so let me end with another quote from the address to the United Nations. This is toward the end. This excerpt says, "It's a violation of human rights when people are beaten or killed because of their sexual orientation or because they do not conform to cultural norms about how men and women should look or behave. It's a violation of human rights when governments declare it illegal to be gay or allow those who harm gay people to go unpunished. It's a violation of human rights when lesbian or transgender women are subjected to so-called corrective rape or forcibly subjected to hormone treatments, when people are murdered after public calls for violence toward gays, or when they are forced to flee their nations and seek asylum in other lands to save their lives. And it is a violation of human rights when health care is withheld from people because they are gay. No matter what we look like, where we come from, we're all equally entitled to our human rights and dignity. And as it has happened so many times before, opinion will converge once again with the truth, the immutable truth, that all persons are created free and equal in dignity and rights. So regardless of our personal values, our cultural beliefs, our religious beliefs, I believe that as nurses we have both the opportunity but also the responsibility to advocate for the health and well-being of marginalized populations such as LGBT people. And I think research is one of the most powerful ways that we can advocate. By doing this, we educate people not only about the issues at hand, but also about what can be done to reduce health disparities. And in this way, we send a message, a powerful message, not to society, not just about LGBT people, but about our care and concern for people as a whole. So with that, I'd just like to acknowledge the many people who've worked with me on my research, as well as those that I've collaborated on other studies. And have to thank NIAAA, who now are about to fund my third major research study, and to the thousands of women who participated in either the CHLU, the INCHLU, or other related studies. So with that, I say thank you. You've been a great audience. I hope you go out and do wonderful things in your life. So thank you. And I'm happy to answer questions if there's time. Yes, Lynn?
Let me ask, what turned your thoughts around about research from being an associate degree nurse to a baccalaureate prepared? Where did the research bite you along the way?
I'll repeat Lynn's question. She asked, I told you I was an associate degree nurse, and I can tell you that before I went to nursing, I was in physical education because I didn't think I was smart enough to be a nurse. And I then did a bachelor's degree, the 2+2 thing, and Lynn wants to know, when did the research bug hit me? And I would have to say, primarily in my master's program, but I also remember one instructor in my undergraduate program who gave me a good grade on a paper and said, I think you should consider the PhD. Now, here I am, an undergraduate, and I'm like, geez, you got to be kidding. That just seems so foreign to me. But working on that research project with Joe and Gretchen, And then I had a lot of academic positions and saw research that was being done and really knew that if I was going to stay in academia, I needed to get a PhD. And then once I was there, I was definitely hooked. Research is the most fun thing that I've ever done. It's like putting pieces of a puzzle together, and it's really, every time you get one to fit, you think, yeah, wow, that's pretty cool. Look at that. So I didn't, probably when I was your all's age, not thinking about it too much, partly because I wasn't sure that I could do it. And I just want to say you can do anything you want to do.
Are there other questions? Tim?
And so by courting and discordant, you mean in terms of drinking behaviors?
Yeah, so your study
Interestingly, we have that information and we have not really looked at it yet. Can you believe that? And now in this next wave where we will be focusing a lot on relationships and how this law we believe will improve relationships, that's definitely something we should look at. And let me just add, again, not a lot of you indicated you're ready for research right now. I know you will be. But I have tons of data, and there's a number of areas that we have not even scratched the surface of. And I'm very open to sharing my data and to mentoring people who want to do work with the data. On older people in extended care facilities or whatever? I don't. Now, my sample is probably average age of about 52 to 54. In that original sample, we've added newer ones. So we are hoping to look at a number of issues related to aging in this study, and maybe do a spinoff to the National Institute on Aging to try to get more in depth. And that's becoming more and more important. Yes?
First of all, thank you for your research. My question would be, may I ask how you got the samples on those who identify themselves as mostly heterosexual women, and what is the criteria? Okay.
When we first started, as I mentioned, there was nothing known about bisexual women. So we recruited women who identified as lesbian. And we excluded women who identified as bisexual. But even though we did that, 11 women in the actual interview identified as bisexual. And as time has gone on, more women have identified as bisexual. In the last recruitment, we asked for women who identified as lesbian or bisexual. Most of our mostly heterosexual women in the CHLU study has come from the national sample. But I also did work in Australia and in these national databases in the U.S., and that's where we've been able to learn the most about the mostly heterosexual women. It's a really interesting group, and if any of you are interested in qualitative research, it would be fascinating to get a better idea of who these women are, why they choose that identity category over the others. We ask questions around sexual identity disclosure, and not surprisingly, the sample is a pretty out group. In the little variation we do have, though, we do see that being more closeted is associated with depression, in particular among Hispanic sexual minority women for some reason. So it's both a positive and can be a negative, because when you're closeted, you're not as subject to discrimination and harassment and those kinds of things as when you're open, but it takes a toll on mental health. So there is some real proven benefits to being more open about who you are. Yeah, Stacy. I would start with making sure you're asking the right questions in the beginning. I mean, at bare minimum, give people a choice not to be, heterosexual and married and all those assumptions. So ask those, and then, really start to do some training with nurse practitioner and other nursing students and physicians around, how to sort of think about this issue, to even have it on your radar screen so that if you get a sort of a sense that somebody wants to talk or there may be something else going on, that you can delve a little deeper. I don't know that we're going to have people asking, do you identify as mostly heterosexual? But huge group of women with clear health risk that we need to figure out a way to better understand and to intervene with. So that's probably the easiest way, the first way. But I hear University of Louisville's doing lots of great things in terms of training, and this certificate, that's absolutely phenomenal. We don't have that at UIC, and we're pretty progressive. We have safe zone training and a few other things, but no certificates. So good on you for, as they say in Australia, good on you for that. But yeah, so keep up those kinds of things, and I think it'll trickle down into the clinical area.
Well, I just want to say a huge thanks to Dr. Hughes.
Thank you.
Thank you so much, Conda. We really do appreciate it. It's a wonderful presentation. And I also want to say thanks to all of you who came today, especially the students and individuals who are participating in the certificate program, and also to our School of Nursing faculty who strongly encourage those of you in several classes to attend. We really appreciate this great showing for Research Louisville and Dr. Hughes' presentation. Have a good afternoon. If you have an opportunity, take a look at our graduate student posters out in the lobby.